Welcome to our presentation today titled Optimizing Practice with Prevention and Health, Wellness, and Fitness Programs. I'm Michael Ross with Damon College in Amherst, New York, and my co-presenters for this presentation are Dr. Renee Haycom and Dr. Lori Walton, who will be speaking shortly from the University of Scranton. First, I'd like to thank the private practice section of the APTA for giving us a chance to present at the conference, and I also want to thank all of you for attending. Here are learning objectives for today's talk. And I'd just like to begin by just talking about, what one of our roles is as a physical therapist. And so as physical therapists, we do many different things. And one of these things that we talk about now that we like to do is this whole concept of prevention and promoting health, wellness, and fitness. And for me, recently I had an interesting conversation with a physician colleague who had still many physicians are still trying to figure out what PTs do, and many other healthcare professionals as well. And I had a conversation, and he mentioned that one of the things that we do really well is help patients exercise more effectively and more efficiently with less pain. And I said, that's exactly one of the things that we do. And we'll talk more about that because many of our physician colleagues want their patients to be able to exercise, want their patients to do more. However, right, they're limited because of some type of musculoskeletal or neuromusculoskeletal impairments that they may have. Again, we have expertise in many different areas that really help us understand how to optimize this movement experience for our patients. We do have direct access, and we are evidence-based practitioners, so we're in a really, really good spot to really begin to work on optimizing our patients with respect to their health, wellness, and fitness activities. Right. Our vision statement for physical therapy is to transform society by optimizing movement to improve the human experience. And we do this through many different ways, right? We're going to speak a bit about these different levels of prevention. Many of the patients we see are at that tertiary level where we're dealing with chronic musculoskeletal or neuromusculoskeletal disorders, and we do a really good job of managing those type of patients. But we also have a role at that primary and secondary level as well. And so I just want to take a moment and just lay some of the backdrop and why what we're talking about today is important. We know that musculoskeletal conditions like back and neck pain really rank near the top in terms of those conditions that really cause a great deal of disability in our patients. If you look farther to the right on this slide, you'll see conditions like osteoarthritis and other musculoskeletal conditions that really, really are challenging for our patients to deal with. If you also look at other causes of disability, we see depression as being another condition that causes a great deal of disability in our patients as well. And many of our patients have a depression comorbidity that we need to deal with appropriately. And so when we talk about the amount of disability that's caused by these disorders, it certainly is quite high, but the cost is also high as well associated with the management of these musculoskeletal conditions. In fact, it far exceeds some of the costs to manage some non-communicable diseases like diabetes and cardiovascular disease. And to kind of put that number into context, right, what does $380 billion look like? Right, that's about $700,000 spent each minute in this country, 24/7, 365 days a year on the management of musculoskeletal disorders. So again, a great deal of disability is caused by the disorders that we manage, but they're costly as well. And so one of the goals that we often have, right, is to allow patients to live longer and live healthier lives, right? But we sometimes don't see that as being the case, right? So the longer we're living, right, sometimes we have some of these comorbid conditions that truly influence the quality of our lives, right? And we begin to look at these factors related to physical activity, smoking, diet, right? And then Lori's going to speak about some of these other concerns about living conditions that we have with respect to our patients. And so many of these conditions come in with our patients, right? And we have to manage these as well in our patients. Again, we start talking about things like diet, physical activity, and how that could potentially influence body weight or body mass index. We also think about things like smoking and how, again, these conditions can influence these non-communicable diseases like heart disease and diabetes. And so Again, I mentioned this at the beginning of the talk that we do really, really good work with many many patients who have end stage disease, right? And we use this, for example, like knee or hip osteoarthritis. We see many patients, right, before they go on to arthroplasty. And again, we do a really good job of managing these folks, right? And so this particular graph, what it shows you, the dark line there, really looks at the patient's level of function. And many of the patients that we see, right, in physical therapy are really having their function influenced, again, by disease that is usually at end stage. And again, we do a good job of managing these individuals. However, I would say that if we take just a step back a little bit and move upstream, right, could we potentially prevent and delay some of these progressions that we see with respect to these chronic diseases? And I think that we can, right? And we'll talk about some of these lifestyle changes that we can help our patients understand and how that could potentially influence their disease. Healthcare teams, I think, are really needed for this, right? And we'll talk more about that as well, but it really takes a team effort, an interprofessional collaboration to help manage these folks through these conditions. And so what can be done from a lifestyle perspective? We've already talked about diet and how that can potentially influence body mass index and our patient's weight. So if we can shift that weight downward, begin to increase appropriate levels of activity, reduce occupational hazards, and improve our educational efforts and social support for our patients. And we play a very key role in helping our patients manage these chronic disorders. Right, and one model that I'll talk about a little bit later as well, but I'll introduce it now, is the Kaiser Permanente model. And this model is used in these adult primary care teams. And so you'll see the team members primarily comprised of physicians and nurse practitioners, but you also see physical therapists, pharmacists, clinical health educators that can help patients understand the importance of diet and exercise, and if necessary, behavioral medicine specialists. And certainly there can be other team members as well, but this really forms the core of these models that I think have been very, very helpful at primary and secondary prevention models for their patients. And so again, part of the goal for this would be to shift that curve to the left, optimize function, and maintain that optimal level of function for longer periods of time with less disease, less disability. And again, we need health teams really for this. And the shift with respect to management really becomes at the point where we're not necessarily looking at managing disease, but again, preventing it. And so this is an interesting study that was published by Ford et al. They looked at 23,000 individuals, and they looked at the incidence of these 4 risk factors in these individuals. They looked at smoking, they looked at body mass index, they looked at physical activity, and then they looked at diet. And they defined body mass index, a normal body mass index as being less than 30. They looked at individuals who were exercising at least 3.5 hours per week. And then they looked at these healthy dietary principles, and they determined, what the effect of these lifestyle risk factors would be if they're managed appropriately on these individuals. And what they found is that if participants had all 4 of these factors managed at baseline, right, they determined that these individuals essentially had an 80% chance of lower risk of developing a chronic non-communicable disorder like cardiovascular disease or diabetes. And so again, these risk factors are important. This study showed that if the individuals had these at baseline, they were very effective. Many of our patients don't. And we know the influence of helping patients understand the importance of managing these risk factors and ultimately, again, helping prevent chronic disease. And so I mentioned a little bit in that study with respect to weight loss or at least a healthy body mass index and a healthy diet. And we looked at that in combination with other factors like smoking and physical activity. But, weight loss is an important component that many of our patients, I think, understand, but sometimes need encouragement with respect to that. And this particular study looking at, the proportion of cases of individuals with knee osteoarthritis, if we have individuals that can reduce their weight by 2 kilograms or achieve a healthy body mass index with that loss, they have about 11% chance, or 11% fewer cases that we're going to see of knee OA. if they can lose 5 kilograms, right? Now we're talking about almost 25% decrease in the prevalence in the OA. And if we're looking at individuals who can reduce their weight until their body mass index is in that normal range, now we're talking about almost a 60% decrease. And so we counsel patients many times on this. I like to look at this as I manage patients over time. We don't typically see weight loss as a dependent variable in many of our physical therapy research studies that we see, but I think it's something that we need to consider, look at this early on in the course of care, and then continue to manage this and help patients understand the importance of this. Again, even if we're not the experts in this area, we certainly can refer these individuals off to folks who are like dietitians or even physicians who have some expertise in managing these individuals for this. And so again, the push here is going to be to move our strategies more upstream, right? Looking at more of this primary and secondary prevention. Again, we're certainly going to manage patients who have chronic disability and disease, and we do a good job with that. But again, the goal here is going to be to try and get to more of the primary and secondary prevention strategies that we talked about. And so I think it's helpful just to present a patient case and just show you how some of this can be kind of moved forward. So this is an individual that we'd seen recently, a 44-year-old woman, and we're seeing her in a direct access capacity 2 weeks following a motor vehicle accident she had. And she was dealing with back pain since the accident, and she had come to our clinic. And the way this works is that, as part of our intake, we normally take blood pressure. And so her blood pressure was elevated. You can see that down here at the bottom. Blood pressure is elevated, and we use an intake with all of our patients. And so we would have information like family history. We would have information like her exercising habits, her smoking habits. And we'd also have some information on symptoms and her past medical history as well. And so we can use those intakes very effectively to help develop a conversation with a patient like this to say, okay, we're dealing with your blood pressure. When have you seen a physician last? Is this being managed? And she hadn't seen a physician since the birth of her last child. And so that was 10 plus years. Again, her BMI was elevated. She's been a smoker since age 18. She's not currently exercising and doesn't have a history of that. Again, hasn't seen a physician, and her family history was concerning as well because her father had an event that led to a coronary artery bypass graft at age 63. And so this patient has several risk factors, for cardiovascular disease and other concerns associated with that, that probably aren't being managed effectively as right now. And so from our perspective, we're certainly going to manage her back pain, and we're going to do that effectively. But from a secondary note, managing some of her cardiovascular risk factors, or at least getting her to the appropriate provider to do that, is going to be an important component of this patient's overall management. And if we look at, again, the clustering of these risk factors, I think it's very powerful to look at the influence that could potentially have. And so this particular study looked at the influence of risk factors in cardiovascular disease. They looked at blood pressure, they looked at cholesterol level, smoking status, and diabetic status to try and determine what the influence that was on disease. And what they found is that if you have a 45-year-old individual like the patient we just described who has 2 or more of these major risk factors, right, their lifetime risk would be almost 50% for a fatal heart attack or stroke. If we look at an individual, we see that on the right-hand side. If we shift over to the left in the box I have circled there, if those 4 risk factors are all optimally managed, right, we see about a 1% chance of a fatal heart event or stroke during that individual's lifetime. And so that's important to understand, that if we can manage those risk factors effectively, right, we can see a significant improvement in morbidity and mortality with respect to our patients. Again, I mentioned the Kaiser model, so I trained here at Kaiser when this model was first put in place to look at controlling blood pressure and the influence that could potentially have. And it really was an all-hands effort. If you managed the patient through the Kaiser system, you were dealing with taking blood pressures and then managing those patients appropriately. In our case, referring these patients off. And what they looked at in 2001 was, could we have a strategy to really manage blood pressure more effectively? They had about a 44% uh, rate of hypertension control in 2001. And over the course of the next 8 years, that increased to almost 80%. And those numbers continue to climb today. And that far exceeded the national average of blood pressure control. And so, what does that lead to? Right? It leads to a healthier lifestyle, leads to healthier outcomes for our patients long term, less morbidity, less mortality, very consistent with the data we just presented in the last slide. And so I think that when we begin to talk about, what our push should really be as we move forward as a profession, I think looking at moving upstream to focus more of our strategies on primary and secondary preventive strategies. Again, we're going to deal with patients who have chronic disability, who have end stage disease, and we're going to manage those patients to the best of our ability. And again, physical therapists do a great job with that. However, many of our patients we have opportunities with, again, to look at those primary and secondary preventive strategies and really, from my mind, become the musculoskeletal manager for that patient, right, for the rest of their lifetime. Again, why us? We have expertise, right, in neuromusculoskeletal assessment and treatment throughout the lifespan. We can assess pain and function, right? We understand disease management strategies. We can have patients access us through, direct access strategies. We use evidence-based parameters, again, to help manage these folks, again, to help patients exercise and maintain that healthy lifestyle longer. And so I think the push would be, how are we going to do this long term, and how are we going to market ourselves to the public? And I'm going to turn it over now to Dr. Haycom, who's going to present some very noteworthy strategies on how we can do this with some different patient populations.
Okay, thanks, Mike. So I will focus on community outreach and some examples of screening to perhaps get out there, get to know the community better, and help to get them involved in your practice. Okay, next. All right, so my objectives: to focus on the role of PT in this health promotion and wellness, particularly in the community. And my example will be related to older adults, but certainly you can apply this to other populations as well. Next. Okay, so starting with health. So you heard Dr. Ross talk quite a bit about health and the role of PT in primary, secondary, and tertiary care. So I have here the World Health Organization's definition, which is comprehensive, related not just to physical health, but also mental and social well-being. So we've used that definition for a long time. And I think recently you hear the term wellness an awful lot, because there are certainly products and programs targeting the public across all different areas. So, when you think about wellness, this definition really gets at the subjective nature of it and how really it's based on the person's perception. So you can have differences between the person's health and their perception of wellness. And this is a dynamic definition where you've got all of these different constructs, such as physical, emotional, intellectual, psychological, spiritual, social, all kind of working together to get at what the person perceives as their wellness. Next. Okay, so back to the role of the physical therapist. So I think, as Mike alluded to, PTs have tended to focus mostly on tertiary care, where we're helping people recover following illness or injury. But I think there's been a push lately, and really I think a lot of PTs are trying to get involved more in primary care, especially related to these non-communicable diseases that people are dealing with. So as far as the role of PT goes, these diseases have a lot of risk factors that are modifiable, which makes us particularly well suited to help people with the management of these conditions. So things such as physical inactivity, unhealthy diet, tobacco use, substance abuse, these are all areas where PTs can play a role. A recent article by Lean et al. Was published in the PT Journal in 2017, and they did a really nice job of outlining this idea of health-focused care, which is really more holistic, more comprehensive, helping PTs to look across all different areas of lifestyle behavior, not just at that single condition that the person was referred to PT for. And then thirdly, just understanding health behavior change. As a PT, it's important to kind of really get into the theories of behavior change and what benefits and barriers there might be to getting these changes to occur in our patients. Because if we don't have a good handle on this, patients may not be able to do the kinds of things that we're asking them to do as PTs. Next. Okay, so this slide here is a figure from the Lean article, really kind of giving an overview of that health focused model that they were describing. So starting up in the upper left-hand corner, it talks about needs assessment and really looking at each individual patient across all of the different types of health behaviors and all of the health issues that they might have. And then having that conversation and determining which factors really are maybe problematic. Down in the right-hand corner, the green boxes really get at the fact that you need to look at readiness for change. So sometimes the patients in front of you may not need to have any changes, but sometimes they really do need to make changes for the betterment of their health, and they may or may not be ready for this. So determining readiness for change can be done through there are surveys available, conversations that you can have, really to get at the fact, do they know about these health conditions and are they ready to make changes to improve them? And then as you move clockwise around the figure, it just looks at assessment, looking at outcomes, and are the changes happening and are they effective? Next. Okay, so in that model of health-focused care, there's also an important factor which relates to really, does the PT possess the knowledge and the skills that they need to really help to prompt these changes in your patients? So a really nice article by Besner in 2015 in the PT Journal really got at specific examples of conditions that PTs might be able to help patients improve, and then specific skills, a specific skill set that would really be helpful to help PTs in the clinic in the management of these conditions. In the center of the slide there, you can see that there are these 5 health promoting behaviors that PTs can really play a role in. These are physical activity, nutrition, weight management, smoking cessation, sleep and sleep hygiene, and stress management. And in the article, there are examples of the types of knowledge and skills that really allow us to kind of do, I think, a personal inventory and see, as a PT, where do I fall in this? Which of these skills, which of this knowledge do I possess? And then maybe considering fine-tuning some of these in your own practice. And you can see they relate to things related to disease, physiology, risk factors, health behavior, as I mentioned, but also counseling. So the role of things like motivational interviewing can really play an important part in your practice. And then things that you may or may not consider, like local and community resources. So going beyond your own practice, but thinking what's out there in the community and how can I do some outreach there. Also, the way you take your history and rapport building with your patients and also with the community can make a difference in the management of these conditions. So at the bottom is just an overview of the kinds of things that are included in PT intervention, knowing that we're particularly well suited to really go after some of these other non-communicable diseases, these lifestyle issues, and that really it's more appropriate to think of it from not just a biomedical model, but think of it from more of a biopsychosocial paradigm, which we are a member of a team, as Mike described, and really we can play an important role in help shifting people toward better health and wellness. Next. Okay, so now with respect to community outreach, so just thinking about how you can take your practice and really reach out into the community in that you're in to try to help make a difference and maybe get people in your door as part of your practice. So the first thing I have on there is thinking about a needs assessment. Related to public health and just related to community health in general, it's really important to get a handle on where are you and what is the population around you like with respect to health and wellness issues. And you can do this a number of different ways. There's existing data that can be easily found online from the Centers for Disease Control, also local health departments, state departments of health, and also community organizations have some of this information that you can access just to get a handle on what are the sociodemographics of the population and what are the health issues that they're dealing with. And then to get more fine-tuned, it's helpful to reach out to these community organizations and try to develop partnerships, just letting people know that you're interested in reaching out and that you'd like to know what are the issues people are facing, what kinds of things can I as a PT help make a difference toward. And so if you can develop this rapport and build some trust with the community, then it's easier to kind of make that next step and get your foot in the door to actually interact with people in the community and meet them where they are to help meet their needs. This third bullet I have on there relates to pro bono services. I think this is an especially useful tool because you can really show that you're serious, show that you're concerned, and do it in a way where there's no cost to the community. You're just kind of putting yourself out there, whether it's through education, screening, just some kind of outreach where you're making yourself known and you're showing that you care. And really, this could be the first step to get your foot in the door and really to help reach out, not only reach out to the community, but also get them maybe to be a part of your practice as well. I would definitely recommend trying to do that first step out in the community. So maybe going out to a local church, a school, a gym, an apartment building, somewhere where you're going to where the people are rather than trying to bring them to you at first, so that you can make that first introduction and develop some rapport. The fourth bullet I have is using appropriate screening tools. So depending on what your target is, depending on your needs assessment, you might want to go out and do some screening. And there are lots of different resources available. APTA has some. I'll share one with you in a few minutes. But just going out and finding the tools that are best suited to screen people for the condition that you're targeting. And then lastly, use this as a marketing example or marketing tool, so that when you're doing the screening, you can have information available about where you're from, where you work, and what services your clinic has that can help to meet the needs of the community. Next. Okay, so my specific example I'll wrap up with is some of the screening and some of the outreach that I've done in the community has been with the older adult population. So when I moved to Scranton, when I started working there, I got to know that there's a very large older adult population. At the time I started, we had the second highest older adult population per capita behind Dade County, Florida. So there are numerous senior centers and community organizations for older adults. We have over a dozen senior centers just in Lackawanna County. So I knew that that was a large population, and I knew that there were needs related to that. So based on that data and also national data, I knew that falls were a big problem. We know that older adults, over 30% of older adults over 65 falls every year, and that number continues to grow. So I went after fall prevention because as a PT, that was an area that I was comfortable with, and that was an area of my practice. And I thought that'd be a good way to get to know the community. So I started with pro bono screening. I used some screening, some simple physical performance tests, some simple questions that I did. So, there's lots of different things that you can look at when you're planning this, and I'll give you 3 examples of tools that are available. So using the American Physical Therapy Association's Academy of Geriatric Physical Therapy, they have some really nice resources available online. The first they have is here through, they provide a clinical guidance statement that they supported from Avon et al. And with respect to screening, they have these recommendations. This is kind of a summary, but it's clear that every older adult should be screened for fall risk at least once per year. So armed with that evidence, it makes sense to go out and do something like this in the community. And they go on further to say that physical therapists should screen every older adult that they come in contact with in their practice for fall risk, because it is such a problem and it's so prevalent. As far as how to screen them, they give some different examples in this clinical practice statement, but just asking questions is important. So asking about falls, near falls, and then asking if there are any difficulties in gait or balance. The PT can also observe and determine if there are any issues, or they could select more specific screening tools. If any issues are identified, if in fact they are at risk and you notice any problems, then a recommendation for a multifactorial assessment that's targeted is suggested. So that's really where you can make that connection from the screening you're doing to saying, okay, you can welcome to my clinic and come in for a screening or come in for a further assessment to help address the problems if you identify the person's at risk or at high risk. Next. 2 other resources that were also available on that website include the U.S. Preventative Services Task Force findings, and those are in line with what we just looked at, which recommends that you take a history of falls and mobility problems. So again, asking that person, have you had any falls or near falls? Are you having problems with gait, with balance? And they suggest using the TUG, which, as you know, is a very simple test to do. It's quick, it's easy, low cost. There's only a few items that you need. The person just stands, walks to a line 3 meters away, turns, comes back, and has a seat. You time that performance, and then you can compare it to existing data on cutoff scores that I'll show you in a minute. And that gives you a good way to interpret whether or not they're at falls based on their history and on their physical performance. If you're looking to do something that's more detailed, you have this STEADY, the Stopping Elderly Accidents, Deaths, and Inquiries. It's a toolkit provided by the Centers for Disease Control. There's a link here on the slide that you can use. And it really gives a nice algorithm and some tools, questionnaires, surveys, and they also recommend the TUG. So again, that's another quick, easy tool that you can consider. There's also the 30-second chair stand. So as the name suggests, it's quick, it's easy, and it can be done in a community-based setting readily. And then they also have a 4-stage balance test that's also another option. Next. So here's a slide that comes from one of the most commonly cited articles from PT Journal from Shumway Cook et al. And it gives how to interpret the TUG. So on the left-hand side, you see they have the TUG and then the 2 different versions of it, either the manual where the person's dual tasking, where they're doing the TUG while carrying, holding a cup, or the cognitive TUG, which is they're doing a mathematical task at the same time, subtracting by 3. And you can see that overall, the TUG is a good predictor of probability for falls. The cutoff scores are here, so you can readily give the person their score and then show them how it compares to these established cutoff scores. So if someone is walking slower than 13.5 seconds, they're at increased risk. You can see the sensitivity and specificity are very good, and an overall prediction of 90%. So the TUG is a good, simple recommendation for you to use for something like this in the community. Next. Okay, so then once you do the screening, you can, again, share that information, and then maybe some of the folks that you meet there, you can target them for further workup in your clinic, really depending on what health condition. Again, mine was fall risk, so you can look at it from having people, welcoming them in for primary prevention, so it doesn't necessarily need to be skilled PT. It could be a program that you have set up for wellness. So maybe you go after the folks who didn't have an immediate need, but you want to keep them healthy. So you can have that primary level program set up. You've also got secondary care options where you're trying to tune people up and reduce those risk factors, where you can help reduce, maybe they need some strengthening, or maybe they need some other types of programs to get them to reduce their risks. And then finally, maybe some of the people that you met during your screening, maybe down the road they do have a fall and they're injured, or maybe there are issues following that, and then maybe they come to you because you developed that relationship and you can see them in your clinic to help them recover and then prevent future falls down the road. So really there can be different types of programs that you can set up, whether it's fall prevention or something else, low back pain, something along those lines that you can address in your clinic. And I think really the important part is to remember that reaching out like this can really help to foster these long-term relationships. So you can have relationships with community leaders, you can have relationships with the patients themselves, and really I think striving to have more of that dental model where patients are coming to you regularly for checkups, for tune-ups, and also coming to you for care when they need it for any type of health condition. Because if you're looking at them holistically, you have a handle on what types of issues they might have in other areas that might need help down the road. Next. Okay, so in summary, so just thinking about your role as in health promotion and wellness, so with your patients using that health focus model in your clinic, and also reaching out to the community. So trying to think about the health of those around you and using that as kind of an opportunity to do outreach, to help serve the community, but also to help market your practice so that you can work together with people for a lifetime. So developing these long-term relationships and trying to do it in a way that is mutually beneficial. So doing it in a way that helps the adults in the community, or the individuals in the community, but also to help grow your practice in a way that you can also give back. So using altruism and advocacy and social justice to really promote PTs as healthcare professionals that really it's really in line with the vision and the mission of the American Physical Therapy Association. Okay, that's all I have on my end. There are some references for you on the next slide. And I'd like to turn it over now to Dr. Lori Walton.
Thank you. So we're going to talk about a specific type of program. We're going to talk about community-based maternal health programs. Next. So why do we care about maternal health programs? Why do we care about them in physical therapy? Why are they important? What is the significance for outcomes for patient populations with this? Globally, 808 women die every day due to complications during pregnancy and childbirth. The majority of them are in low resource settings. We know that worldwide, and we also know that across our nation. Most deaths could have been prevented through adequate prenatal care, and included in that prenatal and postpartum care is physical therapy, our physical therapy related programs. We know that the risk of women dying in a low resource setting is 130 times higher compared to women who have adequate resources and access to care. Prenatal and postpartum community-driven programs have been shown to reduce maternal morbidities and mortality, and therefore we should be very invested and interested in developing prenatal, postpartum, and postpartum programs within the community. Next. So the maternal mortality ratio in 2015 shows a significant difference between countries, with those in lighter colors representative of the lower maternal mortality rates. You can see 0 to 10 out of 100, over 100,000 is the prevalence rate. And that's the acceptable prevalence rate, or the expected prevalence rate. However, anything over that amount, you can see even that the US is over that amount, is unacceptable and is excessive. So the USA holds the highest maternal mortality and morbidity rate out of 60 wealthy, high resource countries. So not overall, but if we look at all of the high resource countries, those that are considered wealthy nations, we are the bottom of that for maternal mortality and morbidity. The USA, compared to its counterparts, reports 17.4 out of 100,000 prevalence rate for mortality during or within those 42 days of pregnancy termination or live birth. And that's compared to Canada, which has 7.4, and UK is 7. Australia is also similar, around 7. And even some of the countries within the Middle East have risen up to 3. They bumped down into that lighter category within the last year. So sub-Saharan Africa, where you see all of the red, holds the highest maternal mortality rate at 554 over 100,000 deaths. What's most disturbing is that while most of the countries across the world are going down in their prevalence rate, Bangladesh, for instance, has halved its prevalence rate. The US has increased it at a substantial amount. So we need to pay attention to that. Okay, next. So 700 to 900 women die each year in the USA from complications related to childbirth, and over 50,000 women have severe life-threatening complications on top of this. So those are the severe life-threatening complications that occur. And above that, we have almost 300,000 women living with some form of comorbidity that's related to prenatal or delivery or postpartum program time period. The USA is 39th out of 39 wealthy industrialized countries in maternal health overall. And maternal mortality is increased by 136% from 1990 to 2013 in the USA, and it keeps bumping up a little bit more each year. Most of that is due to underlying disease, these chronic diseases that we talked about, that Dr. Ross and Dr. Hakam spoke about, and also due to the high incidence of C-section and also the lack of access of care for women, particularly for Black women and women who are from Native American background. So we have maternal mortality in Black women that is 2.4 times greater than white women. And that's after controlling for all socioeconomic status and educational differences. Next. So this map shows the deaths from any cause that's related to or exacerbated by pregnancy, during pregnancy, childbirth, and the postpartum period, up to 1 year after delivery per 100,000 live births. So again, all of those dark blue areas, those are greater than 34.9 over 100,000 prevalence, per 100,000 prevalence. So those are very high levels of maternal mortality within the US itself. And you can look and see some of the southern states. You've got Texas, you've got Georgia over on the right, you've got the Carolina and Tennessee and all those areas that are in that dark blue area. And Missouri and Georgia are number one and number two for high levels of maternal mortality. Okay, next. So here you can see that the US compared to other nations is not faring very well with maternal mortality. Again, that's that 17.4 prevalence rate. Okay, next. And here the difference in prevalence between white and Black Americans in states with the lowest pregnancy-related mortality rates is, if you see on the left there, the difference between the 26 and 9 is 17. So that's for pregnancy-related mortality rates. And then 26 for medium. And then we have a difference of 29 for those that that have the highest pregnancy-related mortality rates. Next. Okay, and here I just want to highlight that, again, we have some real health inequities that are happening related to maternal health care. And we have that the number of pregnancy-related deaths per 100,000 live births, with Black women faring the worst, having 43 prevalence rate, and Native American and Alaskan Native at around 30. Next. Okay, so causes of maternal mortality and morbidity, we have 20% from indirect causes that are from chronic disease processes or infectious disease processes. So we have HIV, liver disease, heart disease, cancer, anemia, and renal problems. And then 80% of them of direct deaths are caused by hemorrhaging, sepsis, eclampsia. Eclampsia is pregnancy-induced hypertension, and unsafe abortion, and obstructive labor. Next. Okay, 60% of these are preventable. Bleeding is the most common cause of maternal mortality in Asia. However, in Asia and Africa, however, in Latin America and the Caribbean, it's from eclampsia, as well as from the US. And in developed countries, it's directly related to access to care and also high C-section rates. High C-section rates have shown to have detrimental influences when they're over 5 to 10%, and the US is now nearing or over 30% C-section rate. Heart disease and stroke cause greater than 34% of prenatal deaths. Hemorrhaging, high blood pressure, and infection are most common in the postpartum first week. Cardiomyopathy is the leading cause of death 1 week to 1 year postpartum. Next. So preeclampsia, chronic disease influences maternal health. These are the different influencers that we can look at. Dempsey showed that in 2005 showed a significant reduction of risk for both gestational diabetes and preeclampsia for women who were physically active throughout pregnancy, beginning with the first trimester. And that reduction in preeclampsia was by 40% with increased physical activity, specifically related to walking 30 minutes every day a week, or at least minimum walking 30 minutes plus for 5 days per week. And 50% for gestational diabetes. So again, this is where we are addressing some of these chronic health issues. So next. Common orthopedic issues in prenatal and postpartum women. I address this because this is a women's health specialty area, but it's also something that most therapists are going to see, because 80% of women who are pregnant or in the postpartum period do have some form of low back pain or pelvic girdle pain. So you will see this within the community, and these are the populations that we're going to are those who may not have access to care to begin with. So these prenatal postpartum programs are crucial to getting some of this information screened, and also getting them to come in for physical therapy in a pro bono clinic setting. I won't go through these, and these again are not exhaustive. They are just examples of some of the things you may see. Okay, next. Okay, talking about vulnerable populations. Again, we're talking about health equity and how to improve that throughout the US and throughout the world. Specifically with the US, we want to look at our low socioeconomic resources, patients who have low socioeconomic resources, trauma and violence exposure, and racial and ethnic disparities we already spoke about. Some of those racial and ethnic disparities that are within our Black and Native American community are due to access issues, acceptability of treatment issues, the availability of treatment, accommodation, and then also affordability inequities. Another vulnerable population, again, these are examples, there are many more that we could have listed here, but another is our refugee population. Refugee women that are resettled in high-income countries have also shown higher rates of preterm birth, low birth weight infants, stillbirths, and maternal mortality. There's a higher risk for hypertension, for diabetes, cardiovascular disease, and other chronic disease. Okay, next. So in addition, ooh, that slide didn't come over very well, sorry. So in addition, if we look at the vulnerable population, we have to also include trauma. And so if we look at the toxic stressors on the right there, that right upper corner, some of those toxic stressors, including war, displacement, conflict, physical abuse, any type of intimate partner violence, any drug addiction, or chemical type of addiction falls into that category. This perpetuates this cycle of trauma, the PTSD, and the related outcomes that happen with that, and that's including executive dysfunction issues, cognitive, emotional, or behavioral difficulties, which may make it difficult for them to follow through with some of the programs, some of the things that we ask of them. And then also with pain, our pain cycle. So some of the outcomes that we see related to pain in the clinic are also just because we don't see them, because we're not going out there, doesn't mean that they're not there. So people are dealing with these things on their own. It's very important for us to go out and into the community to be able to address these issues. Okay, next. So we have a positive stress response, a tolerable stress response, and a toxic stress response. I'm sure all of you have had positive stress responses, as I have when I public speak, where you either take a test or you speak publicly, and then that stressor is over and you go back to your normal level of stress. Then there's tolerable stress, where you might have an individual die in the family, and again, you go through a grieving process, and you know, it may take a while, it may take a couple of years, but eventually you do go back to some sort of homeostasis. But toxic stress is that extreme, frequent, or extended activation of the body's stress response. And that doesn't have any type of buffering system or resilience that's built into it. And I think that this is where one of the needs is for our community-driven programs. Next. Okay, this is, again, I'm not going to go through this. Dr. Hakam went through this earlier when she was talking about how the different micro, meso, and macro levels, the biopsychosocial model, and how that plays into how we express some of the disease processes. So definitely this plays a part in it. Okay, next. Okay, and then if you can see, the toxic stress that we talked about is also in, it's affecting the mind, the behavior, the emotions, culture and society have effects on the patient, and also on the body. So if we look at the mind, the executive dysfunction, decreased cognitive flexibility, impaired judgment, indecision, negativity, poor ability to carry out health and wellness programs, et cetera. And then behaviors could include impulsive, loss of appetite, all of those things listed. Our emotions have increased lability, loss of confidence, agitation, depression, decreased self-efficacy with health behaviors, So it's important to keep in mind all of the players that are affecting particularly our vulnerable populations when we go out and do some form of community-driven program. We also need to keep in mind that structural violence cycle, racial and ethnic disparities and discrimination, and our own implicit bias that may come into our going and doing these programs, or even within the interaction within the communities that we go to. And then of course the body are the things that we're used to seeing, but we need to keep in mind that this is a holistic sort of intervention. Okay, next. So research suggestions for preventive care, Dempsey et al. In 2005 showed significant reduction of risk for both gestational diabetes and preeclampsia in women who were physically active throughout pregnancy. This meant, again, 30 minutes of activity at least 5 days a week. And this was preferable to start in the first trimester, but could be started by anyone without a high-risk pregnancy throughout the pregnancy, and it helped with reducing these. And these are huge, significant factors, because remember, preeclampsia was one of the major issues for maternal mortality. So though we may not have a direct effect, we can have sort of this distal effect. Aspirin was also shown to, I placed that in there because that is an important one that they've just found, and not directly related to PT, but definitely information-wise, we can tell our patients that aspirin that was started at less than 16 weeks also helped with that. Interestingly, there's a mouse study that was by Janest et al. In 2010 that showed improvements of free placental growth factor and decrease in VEGF, which inhibits some of the anti-angiogenic factors like tyrosine kinase 1 that's often seen in preeclampsia. Again, preeclampsia was one of those major outcomes for maternal mortality, or reasons for maternal mortality. And interestingly, exercise has been shown to help with placental development, decrease in oxidative stress, improve endothelial function, and immunity and inflammation. So this had a direct effect on the preeclampsia. Next. The role of physical activity has been shown throughout the literature for maternal health. Regular physical activity definitely improves metabolic, physiologic, and psychologic issues during pregnancy. Reduced mortality and morbidity with regular physical activity of greater than 30 minutes on all days has been shown in several different studies. Physical activity also improved cardiovascular fitness, reduced muscle cramps and low back pain, and reduced gestational diabetes and hypertension. Physical activity also improves stress tolerance and mood stability, particularly with our vulnerable populations. If you remember that toxic stress, it was a facilitator of resilience. Reduce labor time and reduce complications with delivery also. Okay, next. So the role of the physical therapist in community-driven maternal health programs includes screening and advocacy, prenatal and postpartum exercise programs, patient education on health and wellness during pregnancy. This includes also nutrition and breastfeeding. Patient education on risk factors and programs to work on chronic disease-related issues, advocacy for wellness, including walking programs and nutrition, stress reduction programs, resilience programs, and pro bono clinic referrals for specific orthopedic issues or neurologic issues for that matter. Okay, next. These are some treatment considerations. I'll let you mull through them. We don't have time to go through them individually. Next. And here are some selected, very selected suggested outcome measurements. These are ones that I use in my own prenatal postpartum programs in the community. And I just took the health-related quality of life you can look at. There's a couple of different ones. SF-12 is an easy one as well. And a stress scale, perceived stress scale, PSS. There's a PSIQ, I believe, for sleep, since that was one of the indicators. Physical activity, the IPAC short form's an easy one to do. And then we have some pelvic floor specific ones that you can look at if you're interested. Next. So considerations, pro bono programs for vulnerable populations are part of responsible and ethical PT practice where these programs are indicated and feasible. The best response from community-driven programs are those that provide resources for long-term sustainability. We don't want to just jump in and start a program and then jump back out, because that really doesn't do much good for the community. We want something that's sustainable. Is it feasible? And what are the needs for that particular community? Don't assume ever. Acceptability. Is it something that's acceptable? Will patients come to these programs? Will they be able to get there? Is there a gender transformative framework for these maternal health programs? In other words, do we have enough investment in knowing what are the different barriers for women to come to the program? What are the different facilitators? What is their role in their own health? It should be multidimensional. It should be collaborative with multidisciplinary teams, particularly with social work or psychology. And if you can get an obstetrician on board, that's even better. And then high adaptability to changing circumstances and population needs. Community-driven maternal health programs have both distal and proximal effects on improving health equity and reducing maternal mortality and morbidity for women. Obstetric physical therapy programs are really a PT specialty area and should only be attempted in collaboration with physical therapists who hold special training in OBGYN, PT. However, with that being said, if you are able to take a couple of the courses, there is a certification for OBGYN that is 2 courses through the APTA. You can take a look at that, and all PTs are able to do that. You don't have to have the membership to do that. Waivers of health participation from the MD should always be sought. If there's any red flags, you need to address them, of course. And when working with trauma survivors, we really want to always make sure that we're working with someone with social work or psychology background, and have an MD on hand, usually by phone. Okay, next. Okay, so these are my selected references, and I just want to say, we all want to say thank you for attending our session, and we hope that you found some of this valuable. If you have any questions, you feel free to email us. Thank you.